Turn your group practice into an IOP or PHP in New York before the model is validated, and you commit capital to a program that may not hold. New York already has many intensive outpatient programs. There is real unmet demand, but not every market can support another IOP or PHP. This is not legal advice or a launch checklist. It is a readiness screen for converting a New York group practice into structured outpatient addiction treatment. We will walk through what to validate first: the OASAS path, payer terms, site fit, your documentation model, and staffing, before you commit capital. An IOP can be a natural outgrowth of a group practice, especially when your team already treats substance use, co-occurring needs, trauma, or family systems. Group practices already combine shared risk with more control over caseload, clinical direction, and hiring. New York's parity laws are intended to improve access to behavioral health coverage, but reimbursement terms should be verified with each payer. Adding an IOP or PHP is a readiness decision, not a setting you flip. The work happens before you announce. Market the program or build a payer-dependent revenue model before you validate the path, and you risk launching a service the market or your contracts cannot support. Validate the OASAS path, referral need, payer terms, staffing, site fit, and documentation model before committing capital or marketing. Searches for New York Medicaid IOP and PHP billing should lead to questions, not reimbursement assumptions you build a launch plan on. A purpose-built EHR and CRM are designed to make the transition from group practice to IOP smoother. But software does not replace licensing, payer, clinical, and implementation review. Behave Health's EHR, CRM, and RCM are designed to support the program once your operating model is ready. The clinical, payer, and licensing decisions come first. The platform supports admissions, documentation, and billing after those are scoped. It is designed to make the conversion smoother. It does not replace the work you do with OASAS, payers, and counsel. A real readiness screen covers 5 areas. Resolve each one with the right partners before you announce a launch date. Let us walk through all 5. Step 1. The OASAS path. Start with which agency has authority and which service definition actually applies. Identify the OASAS source path and which agency governs the service line you intend to offer. Confirm whether the group practice model still fits the state's service category, or whether the structure has to change. These decisions should be scoped with OASAS, counsel, and an implementation team before any public marketing. Step 2. Payer terms. Verify enrollment and credentialing instead of assuming the revenue model. Verify provider enrollment and facility or program credentialing with Medicaid and commercial payers. Confirm medical necessity criteria, documentation expectations, authorization review, and level of care billing. Do this before relying on the revenue model with payers, counsel, and Behave Consulting. Step 3. Site and level of care fit. Do not assume your current office is ready for structured outpatient. Validate local referral need, real demand for the specific level of care in your specific market. Pressure test your site assumptions and level of care fit before you commit the location to the program. Step 4. Documentation and admissions. Define how the program will document care and run intake. Set your documentation standards and authorization workflows to match payer expectations. Design admissions operations for structured outpatient, not the workflow a group practice runs today. Decide who owns utilization review before the first authorization is ever requested. Step 5. Clinical leadership and staffing. Confirm who leads the program clinically and how it is staffed. Confirm clinical leadership and level of care fit for the program you intend to run. Design staffing for structured outpatient before you commit to a launch date or public marketing. If you are already asking these questions, the right next step is a private readiness review, not a launch announcement. Does this OASAS path fit our model? Can our current site support the service? Which payer assumptions are actually real? Who owns utilization review? And what has to change before we market IOP? Behave Consulting helps group practices translate those questions into an implementation plan. Then Behave Health software supports the program once the operating model is ready. The plan covers certification readiness, clinical operations, and payer sequencing. It also covers admissions, documentation, and software setup, in the right order. Stop marketing an IOP or PHP before the model holds. Pressure test the New York conversion before you commit to a launch date at behavehealth.com. Talk with Behave Health before you commit to a launch date. Book a private readiness review at behavehealth.com.